Welcome, everyone, to a discussion on confronting social isolation and loneliness in older adults. My name is Steven Collens. I'm the CEO of MATTER. So to make sure we're all talking about the same thing, loneliness is the feeling of being alone, regardless of the amount of social contact. Social isolation is a lack of social connections, and social isolation can lead to loneliness in some people, while others can feel lonely without being socially isolated. According to the CDC, before the pandemic, 1 in 4 Americans aged 65 or older were considered socially isolated, and social isolation for adults aged 50 and over significantly increases their risks for premature death, dementia, and heart disease. It's also associated with higher rates of anxiety, depression, and suicide. And of course, all of these issues are exacerbated given the need for us to remain physically distant in the time of the COVID-19 pandemic. To unpack the challenges and explore innovative solutions, I am thrilled to be joined by 3 individuals who spent their careers working to improve the care, health, and happiness of older adults. Dr. Sachin Jain is the president and CEO of SCAN Group and SCAN Health Plan. Before joining SCAN, Sachin ran CareMore Health and Aspire Health, 2 integrated healthcare delivery companies. And under his leadership, CareMore built and scaled industry-leading programs to address loneliness, deliver hospital and primary care at home, and address the clinical needs of the highest risk, highest need patients. Dr. Jain is frankly kind of a big deal in the world of healthcare innovation, and we are honored to have him with us for this program. Dr. Sonja Rosen is the Chief of Geriatrics at Cedars-Sinai. She is board certified in internal medicine, geriatric medicine, as well as hospice and palliative care medicine. Her research and clinical interests include safe transitions of care and safe prescribing in older persons, geriatric co-management, delirium education, population health, Medicare Advantage population management, and addressing social determinants of health and fall prevention. And finally, Ruth Poiakine Baruchi is the co-founder and CEO of MyndYou. MyndYou helps Medicare Advantage health plans increase member engagement and remotely monitor, detect, and manage emerging medical conditions in a cost-effective way. The company uses artificial intelligence to assess brain activity and provides insights into the evolving health status of at-risk and older adults in their homes. Before starting MyndYou, Ruth spent more than 2 decades in leadership roles, mainly in digital health and health tech for older adults. MyndYou has been a member of MATTER for about a year, and we are delighted to produce today's event with Ruth and her team. One housekeeping note before we get started: as the event unfolds, please submit your questions using the chat function. I will weave them into the conversation as we go. So with that, let's get started. And Sachin, I'll start with you, and maybe a simple question, but why are we talking about social isolation at a healthcare event? There's been a movement that I think is accelerated in recent years that the things healthcare systems and practitioners worry about include nutrition and housing and environment and things like loneliness. And, is this what we should be talking about at a healthcare event?
So I think if you're a clinician seeing patients out in the world, you see loneliness every single day, and you see it come in people of all ages, and you see it manifesting in different forms. One of the things that you also see is that it has a profound effect on the spiritual as well as the physical health of the patients we have the privilege of caring for. Lonely to connect, to join with others is really, for many people, what being human really is all about. And so when we see people who, for whatever reason, find themselves socially isolated and unable to connect, we want to do something for them. And for years, when we would see patients like this, we would have nothing to offer them. And I think one of the exciting things that's happened over the last number of years is that there have been a number of us who've tried to work to actually build interventions so that just in the same way that you can prescribe a medicine when somebody has diabetes, you're able to prescribe an intervention when a person is suffering from loneliness and social isolation. We know that people who are socially isolated or lonely are admitted to the hospital more, they get readmitted to the hospital more, and ultimately participate in preventative healthcare screenings with lower frequency. They, in simple terms, they participate in self-care less. And so I think we have an opportunity as a healthcare industry to take this issue on. At the same time, I'll just say, I think there's a tendency and a risk to over-medicalize everything. And this is a problem that's going to require the engagement of the healthcare community, but our plates are pretty full in healthcare. But it's also going to require, I think, a new social contract for all Americans, particularly as we kind of enter this new phase of our country's history, where we commit to each other more. We're participating in actually engaging with each other more.
Well, thank you. I definitely want to come back to that. But Sonja, Sachin mentioned briefly a little bit about the link between social isolation and health outcomes, and I'm hoping you can dig into that a little bit more and share what it is that you've seen in your research and your practice on that topic.
Oh, absolutely. I mean, really echoing what Sachin shared. Lonely individuals they're less likely to exercise, remember to take their medication, engage and even see their physician, or even eat well. And there's a lot of multi-complexity. There's a lot of layers to the reasons why. Usually a person who is socially isolated, which is a really critical social determinant of health, usually they're going to have other social determinants of health that are insecurities. So they're probably, they may be financially insecure. They may have housing or food insecurity. So there's a great deal of overlap for an individual older person who's socially isolated. They're probably going to have one or more of these other social determinants of health that are really critical to their well-being. A perfect example of that is a person who doesn't have the ability to get to a senior center where they can get a warm meal, may also not have that ability to get to their physician readily, get to the grocery store readily. So there's this really clear overlap. And quite honestly, these are definitely our responsibilities as clinicians. If our patients can't be well nourished, if they can't get the medications we prescribed, if they can't participate in the exercise class we recommended, then we aren't really helping them get better. So it's critical that we recognize social isolation as well as the other social determinants of health. We see these as medical problems. And then utilize, as Sachin was saying, evidence-based programs, whether they're in the community or in our health system, to help get our patients more socially connected.
Thank you. So you Sachin, I just want to come back to you, and then Ruth, I want to have you chime in. But you Sachin, you said a moment ago that there's a danger of over medicalizing these issues, and just heard Sonja say very clearly that this is a medical issue. How do you think about it, and where's the line between things that are medical issues per se and things that are in, I guess, somebody else's problem?
Yeah, I mean, I'll say that health professions and health professionals are a self-flagellating bunch. We take responsibility for a lot of things, many of which we should take responsibility for, and other things we still take responsibility for, even though there are other factors contributing to various problems. What I can say, definitively is that, the number one solution to addressing loneliness in our society is stronger families and stronger communities. And so while I do believe that medical professionals are powerful in their capabilities, we aren't necessarily always able to help people create stronger families and stronger communities. And so I think that this dialogue always needs multiple tracks. There's the track around identifying lonely patients in the exam room and doing what we can as medical professionals and healthcare professionals and as a healthcare industry to help solve these problems, but to not kid ourselves about the fact that we need, I think better a better approach as a society from a public policy perspective, from a social structure perspective. We need a different approach to aging. We need a different approach to community engagement, where people don't feel quite as socially isolated, and people care about their neighbors, and people care about their grandparents. There's no substitute. There's a number of companies that have emerged to have, so-called grandkids on demand. What about people's own grandkids? We can't commercialize every single social problem that we have into a solution. I commend everyone who's working on building solutions, but the real thing that we need to do is I need to call my grandmother more, and I need to visit her more and be present with her more. And there's no substitute for that. We just have to kind of make sure we're having an authentic dialogue about this. And even as we're working to build solutions that we can deliver through the exam room and other vehicles as well.
And is that what you were talking about when you said we need a new kind of social contract?
We do. I mean, the funny thing is that this problem is getting a lot of attention right now because books have been written, articles have been written. We've all experienced the social isolation that's come with the COVID pandemic. And so it's a top of mind topic, but the intellectual history of this problem is a lot longer. I happened to be a student of Robert Putnam when he actually published the book Bowling Alone in 2001, which documented the pretty significant decline in social capital in the United States between the years 1960 to 2001. And the reality is that we've, as a society, started to fray. Where we once made community number one, many of us have made the individual number one. And so, again, I think we need to take a big step back and recognize that there are untoward effects and side effects that we all experience from a society where the individual may take precedence over the community, and family units where the individual takes precedence over the family unit. And so, not to sound like a neoconservative here, because I'm not, but I do think that we really need to believe, I think very strongly in kind of thinking about this not just as a medical problem, but as a broader problem that our society needs to solve.
Ruth, so you have a technology company that is using artificial intelligence. You're deployed in a number of areas, and you are helping address this problem. I know you're not doing it by forcing people to call their grandparents more frequently. So talk about the role of companies like yours in helping address these challenges that I think Sachin has characterized nicely as really stemming from more of a systemic cultural issue that we have.
First, I'm really glad to be with all of you today and to participate in such an important conversation and connecting with what Sachin and Sonja said earlier. It's all about the people, first of all, and I'm the technology person in this panel, so it's really important for me to say when we began and designing MyndYou solution, what we had in mind and where I see technology bringing value to impact our everyone, seniors, as well as our society, is really in bringing better awareness of the needs of seniors that are socially isolated and lonely, or suffer from different diseases that are not always known or identified. So based on conversations that we're having with our customers, health plans, health systems, a lot of what we hear is that to care and take care of people who are socially isolated or lonely, for their families to be aware of that and for the healthcare system to take care of that, you first need to identify that. And with that, where our solution and other solutions bring value is really in the ability to identify a change in a scalable way, though, where sometimes the care of human, family, or systems, as much as you want, you don't have the scale. So our solution, MyElinor voice care management, AI-based care management, basically allows to scale the reach to seniors, giving them a very natural experience, speaking on the phone rather than utilizing complicated technologies, and speaking and sharing. And through this communication, which is not human, but it's a very high touch though, and with a very strong technology on the back end, there is an ability to identify when a person does need help, where he or she do need access to services or care, and connecting them with the actual services. As we look at it in a broader way, it could be having his care manager, which we work with today to know that something has changed, get information. It could be his family members or his friends down the road getting an indication, getting awareness around the need of their care or their loved ones. And with that, I wanted to maybe share one simple one of many stories that we've seen in one of the MA programs that we ran, where MyElinor calls on a twice-a-week basis seniors in their home that opted into the program. And I'll tell you a story just about one man who recently lost his wife. She has been his main caregiver and friend, actually, which is not as important, I would say. And in his conversation with Eleanor, he told her, "I have no friends. I spend my days staring on four walls. What boring life," he said. You need to hear that to know that. You need to speak to someone to know that. And there is a need to have enough people, or with technology's help, means to communicate with someone so he can share that. At the end of one of the calls, in a more optimistic way, the man I'm speaking about told Eleanor, speaking to her on the phone, "Thank you for calling me." So this is one example of how we can all get more aware of what's going on and in an actionable way, while the care management team of the plan of this man was aware and elevated of this information. More data around community services, such as the ones proposed by plans and systems, which we'll talk about more, were offered to him. A hotline to a mental health service was offered to him. And that's how I see technology contributing in a human touch way, but scalable to the ability to give better care to seniors who are isolated and lonely.
It's a bit of a tangent, but I find it kind of fascinating, and I think others might too. Can you just talk for a minute about like how the technology actually works to tease out from somebody that your system is talking to? You gave a really clear example where they were very clear, but I think, as I understand it, they don't necessarily have to be quite so direct, and your system can still tease out that that they should be flagged for potential intervention.
This is true. So first, the technology, and going back to human, I'll speak about that too, was built, it's an AI-based technology that allows detecting changes in the way the person speaks, how he speaks, and what he speaks. So not necessarily detecting specific words that were said, but a combination of the spoken and the unspoken. That's the technology in the background. the ability to engage with seniors using My Eleanor, who is the face of our solution, she's the one calling seniors, was built based on tens of thousands of hours of experience of clinicians that were using the system, engaging with seniors, learning how to communicate with them, learning how to engage with them, how to make them feel comfortable speaking to a person, and later on, even though it was hard to believe, to a computer. And the brain of clinicians was built into the machine with really the intention to make people feel comfortable speaking. And once they speak, our analytics engine in the background is able to detect changes in the tone of voice, as well as in specific words that are, such as fall, such as food access, such as depression, and sometimes things that are not reported and it can be elevated based or detected based on how the person speaks over time. We get the chance with this technology to get two main values. People are happier, they enjoy, they feel cared for. They know that someone listens to what they tell Eleanor on the back. So care management in the plans and health system example. And at the same time, when something is changing from the baseline, from how they're doing, the technology is able to detect it and elevate so that care managers can be more efficient, more productive, and get the care and the attention that the senior or the member needs when they need it.
Thank you. It's it's really helpful, and it's fascinating technology, and it's been interesting to kind of watch over the last several years as having known you, how it's evolved. So Sonja, I'll come back to you. So there are, whether it's through a solution like MyndYou or, or other ways or more manual ways or other digital technology, it's, you can screen people and you can identify and recognize people who are, having issues with social isolation and loneliness. So then what? Sachin earlier on mentioned that there was a period of time where there wasn't really much to do, and now it's possible to intervene and do things. So, in your practice, what do you do?
Well, I just have to share, it's so wonderful hearing all of these perspectives and even more about the work that your organization is doing. I think actually the lift is not that tremendous. And I'll say why. I think, first of all, clinicians, we need to recognize this as a problem. We need to recognize that just as hypertension and diabetes are problems that we need to manage, so are things like social isolation and food insecurity. And I think that in and of itself doesn't just raise awareness, but it tells the patient this is important, because it's important to your physician. It's important. This is meaningful. This is important, and we want to work to help solve this problem. That said, I 100% agree with what Sachin was sharing. Is we just don't have all the solutions, but we can sort of be that spark of activation of, we have a problem, and let's start the process of how to deal with this problem. And the reason I say, and again, it depends on the community we live in. In Los Angeles, we have this wonderful Purposeful Aging Los Angeles movement, which is a county-wide movement under Laura Trejo's leadership. There are so many amazing community programs that are in existence that help combat social isolation and loneliness. There are incredible evidence-based programs like the wonderful Togetherness program that Sachin created at CareMore. We have a LEAP program at Cedars-Sinai using evidence-based exercise classes now virtually to help combat social isolation, and your wonderful organization and technology. So the point is, we have so many programs. We have, I would say, an exhaustive list of programs in the community in Los Angeles alone that do exactly that. But what we need to do is connect patients to the program. And at least at Cedars, we're doing that with the use of a health coach. I know a lot of health systems employ health coaches or use care coordinators or case managers in this capacity. But really, when I think about the lift of the future, you know, this is, I 100% agree with Sachin. These are, you know, really community issues. These are global issues about how we value how we care for our families and our communities. I do think the work is being done. I think the work is tremendous by our community leaders and our local government. And I think we just need to make those connections. And so, you know, you asked how we're doing it. We created this program leveraging exercise to age in place with the support of the AARP Foundation, really employing the use of a health coach to connect our community members and our patients to evidence-based exercise programs. But sometimes that didn't work for them. And sometimes patients weren't interested in exercise. So then we connected them to a local art class at the library pre-pandemic. And so really that's the thinking that I have is the programs are out there. We just need to recognize this is a problem and then connect our patients and non-patients, even our community members, to these programs to help get them further connected.
Sachin, who pays for these interventions? And you know, you started a program, and actually maybe it'd be helpful when we heard a little bit about the LEAP program. Sure. that Sonja's done. When you were at CareMore, you started a program, and so now with your view from kind of your position at SCAN, I'm interested in both of those things. So a little bit on kind of what you created, what you're trying to do at SCAN, and then kind of generally, like who pays for these things, and where do the dollars flow?
Yeah, it's a great question, and I would say in a fee-for-service healthcare system, nobody pays for them, and I would say in a risk-based capitated healthcare system, such as Medicare Advantage, where healthcare provider organizations often take on full risk for the care of their patients. Intervening upon loneliness can actually, be a driver of better outcomes, which can, be a driver of lower costs of care, which is ultimately, what we all want, because if patients need less health care, that means that they're healthier, and ultimately risk-based providers, that end up actually, saving some money. So, I've now worked in 2 organizations that are kind of knee-deep in taking full risk or delegating full risk. CareMore was a risk-based provider, and one of the things we did was we built this togetherness program, which had I think a couple of important components. One was actually naming the problem of loneliness and doing so in a non-judgmental way that didn't stigmatize people, kind of focusing on togetherness as opposed to loneliness. I used to joke that Britain announced a minister of loneliness, and we had much better branding than Britain because we focused on togetherness as opposed to loneliness. Nobody wants to talk about being lonely. And what we did was we essentially trained a group of folks to make outreach phone calls to people we knew were lonely. We also had screening in place in our clinic visits where we would identify people who either self-reported that they were lonely or a clinician believed that was lonely, and then those folks would get referred to our togetherness program, and then that program would reach out to folks on a regular basis and oftentimes connect them to community-based programs. We had fitness classes at our care centers, and we had individuals, participate in these group exercise activities, which oftentimes created these new social connections in the community that people didn't have. We had many stories of people who would get married at our nifty after 50 gyms that we used to operate. And so these were, I think, it was really connecting the dots, both screening and identifying people who were lonely in the exam room, as well as connecting folks to resources and then providing these outreach connections. And I'll tell you, it was very profound. Oftentimes people would answer the phone and say, "Hello, Armando." And the reason that they would say, "Hello, Armando," was because no one else would actually call that person. So that is the state of growing old in America for some number of people. And so that, always kind of stuck with me as a reminder that while we can kind of think about this in our own context, we sometimes can't even imagine how lonely and how isolated, some seniors are, with literally no one else in their lives checking up to see if they're still breathing, to put a kind of fine point on it. SCAN, in parallel to CareMore, actually built a Member Connect program, which was essentially, we employed some of our members. This is, we have 30 or 40 members who are on our payroll to actually reach out to folks and connect with them and check up on them. And, folks are identified as being socially isolated by our care managers, by clinicians in the field, then they will get phone calls from seniors. And it's really seniors connecting with seniors, which we found to be incredibly powerful because, there's a much higher degree of empathy when, you have people going through a similar stage of life together. And I think that's been a profound learning from our programs at SCAN, which is, oftentimes, there is value in intergenerational connection, but intergenerational connection isn't for everyone. An empathic connection can really be built with seniors connecting with seniors. And so, we've found real tremendous benefit from that. And, it's a program we're going to continue to expand on and scale in the weeks and months ahead. The thing I want to point out about all of these programs, with the exception of Ruth's, where there may actually be some rocket science, is that it isn't rocket science, right? I mean, this is really pretty low-tech stuff. It's people getting on the phone and calling folks. It's people showing up to check on folks. That was a component of our Togetherness program. We had a home-based, friendly visitor program. Literally anyone could organize a program like this. There's no IP here. This is pretty open source. And so, what I would just say, again, it goes back to this question of where does the will going to come from? Because, ultimately, these are solvable problems. This is not, kind of developing a COVID-19 vaccination in 6 months. This is something tomorrow, if I wanted to go work on my, elderly neighbor's loneliness, I could. And so the question then just becomes, how do we become a better society where that's a part of who we are and a part of how we operate, and where we can leverage both high-tech solutions like Ruth's, but as well as low-tech solutions like just checking up on your neighbor, so that the work of doctors and nurses becomes a little bit easier, because I do think we have a tendency to take on way too much in the exam room. We have a long list of issues we've got to address. Loneliness is one of them.
So I definitely want to come back and in a minute, Ruth, to you and this notion of rocket science solutions and kind of what are the possibilities of technology. But Sachin, just want to probe on one thing related to kind of who's paying for this. And, you mentioned very clearly that in a fee-for-service environment, nobody's paying for this. And, that you could fill in the blank on a lot of things that are easier to envision a payment scheme under a value-based care scenario or risk-based scenarios. So, we're moving, I think the healthcare system in general is moving slowly in that direction. And so we can all just wait for someday in the future when there's a kind of widespread value-based care initiatives. If we wanted to accelerate that, is it an awareness, specifically around loneliness? How do you think the awareness is out there about the scope of the problem and the actual medical implications of the problem?
So I think it's actually, this is where physicians can be good stewards for their patients. I mean, I don't want to be too much of an industry shill here for a second, but I will get on my soapbox for a minute here. Medicare Advantage is a program that on average provides Medicare beneficiaries with substantially more benefits in the form of wraparound services for social determinants of health, interventions for loneliness. And these Medicare Advantage exists in almost every county in America at this point. There's a lot of competition. There's actually a higher degree of care coordination. There's a good view that that Medicare Advantage programs actually produce better clinical outcomes in patients because care is more integrated, because it happens in narrower networks. Now, it's not a perfect program, and so I want to be very clear about that. It's not a perfect program. people have problems with the narrow networks that are imposed on them. Ultimately, there's pre-authorization, which creates a lot of abrasion for people in the Medicare Advantage program. But we as physicians, to extend on Sonja's point around advocacy on behalf of our patients, in addition to being advocates for their clinical health, have to also be advocates for making sure that patients are in clinical and financial scenarios that actually create the best outcomes for them and create higher degrees of integration and coordination of care. And, most patients, most seniors don't know the difference between fee-for-service and, integrated care. And it's our job to until it's too late, and it's our job to actually teach them that. And all it takes is someone, kind of bouncing to and from lots of different parts of the healthcare system to suddenly realize how not integrated, care is, even for those of us with a lot of social capital and financial capital. You can't buy really good care in the fee-for-service system. You can buy good episodes, but as far as, threading it all together, it's really not very well connected or coordinated. And that's one of the things I think Medicare Advantage does really well. And so, again, I think the thing that we can do as clinicians is we can, inform patients about the differences between these different models. And again, I think clinicians, for their part, end up getting compensated more, typically in Medicare Advantage, for keeping their patients out of the hospital, for being available 24/7, for creating, solving their problems when those problems arise, as opposed to letting them progress and become, complications that are, ultimately preventable or treatable. And so, again, I think there's this awakening that needs to happen that, we need to be interested in this topic of insurance coverage. When I was a medical student, I used to advocate for health policy at, integrating the curriculum for just these reasons, because there's this, naivete in the medical profession around the interface between financing of care and the delivery of care that gets ripped away as soon as you enter into practice and you realize that it actually all really matters. And so I think we have to become, again, broader stewards of the healthcare system and of our patients and how they interface with the healthcare system.
So Ruth, coming back to the rocket science point, you have an artificial intelligence solution which presumably allows you to do at scale something that would otherwise require hiring a gazillion people to make calls and knock on doors. And how do you measure the success of your solution? What does that look like? What are the right measurements? What are the right tools? What are your customers asking you to measure for them?
So I think connecting with what Sachin just said, first of all, you need people to want to speak, right? So engagement is a significant measurement or KPI for MA plan, especially this year with Medicare Advantage plan rating pointed going up to be satisfaction becoming, member satisfaction becoming 57% of the total rating of the plan. This is a way to recognize how engagement and satisfaction of the members is an important part. So engagement is one part of it. And in a recent program we've just done, we've been able to show engagement of 94%. A retention of 94% of seniors happy to speak week after week, some of them twice a week for 5 minutes on an average, and some of them less, right? Some of them 50 minutes with my Eleanor, sharing with her. So this is one, I think, basic and really important aspect of measurement. How much people are ready to speak in terms of length of call, but also in terms of length of service. So some people are different. Some people want to speak to seniors, others want to speak to providers. Different people have different needs. The advantage, one of the advantages of my Eleanor and the technology is that she can allow for personalization, which makes engagement stronger, I believe, because people feel like they're getting what's the right thing for them rather than just a generic solution. So this is one parameter, and I think it's an important one thinking in a broader way, also, it can allow for hybrid programs. So when people engage over time, they can be referred to human services, such as the one mentioned by Sachin, when it's the right time, when they need it. But some people don't really want it. Some people just want for someone to check up on them.
Yeah.
And they would continue engaging, maybe not every week, maybe once every 2 weeks or 3 weeks, but they would know that someone checks up on them, and that's where the engagement from their perspective would continue to be high. So this is one very important parameter. A second important parameter that we see specifically with Medicare Advantage plans, going back to cost and improve of outcome and reduction of cost, is productivity, allowing plans to be more cost effective, reaching to more members in an efficient way. So care management is a tremendous tool for Medicare Advantage plan. I think they're doing beautiful work, but it's limited in the ability to reach to members and give the right attention. So this is another measurement, how technology can help, where we've been able to show very nice results, improving productivity of care management. And the other side of it is improving outcomes by getting the cases that require attention at the right time to care management, who can actually do, or providers, physicians. So another data point from recent program, 70% of the elevations through based on detection that our technology has done in communication with seniors were actually translated into intervention that improved outcomes, meaning a human got the report from our system based on the analysis that my Eleanor's brain did on the background, and were able to intervene, to call or to connect the person with the service in a way that reduced the chances for him or her to end up in hospital. These are three main parameters that were being measured for, which is connected to what the plans are being measured for in terms of their value.
And how often do people answer the phone when my Eleanor calls? Do they, you know, is it like people answer the phone?
So there are two main paths for my Eleanor. The main one of them is really based on a lot of that we've learned in the last 4 years with clinicians' work, is where people opt in to the service, saying when do they want to be contacted and how frequently. So they choose the time they want to speak to my Eleanor. Comfortable for me to speak to her at 10 a.m. once every 2 weeks. And they would choose the frequency. Some choose once a week. Others would want to reduce it after a while to less. We've seen in a program that we just ran, people started the program with twice a week calls, again, an average of 5 minutes conversation. And at the end of 3 or 4 weeks, they were asked by Eleanor, do you want to opt out or drop to one time? Actually, more than 50% of them opted in to stay for twice a week, which was surprising for us. And the rest opted in to continue at the once a week basis. I think that the important item here is to be respectful to seniors. We want seniors are people just like us. We want them to choose the service. They want them to choose the way they want to get their care. And again, technology has the advantage of the ability to be adjusted in an easy, relatively way and in a low cost to the need of the member, the way they ask it.
Sonja, when you're evaluating solutions, whether it's a digital technology or something like the LEAP program that you described, how do you measure the ROI of those programs? What are the metrics that you're you're looking at, and what kind of successes have you had?
Yeah, I mean, that's such a great question. That was actually the answer that I had for how do health systems, choose to implement these programs? What makes it worthwhile? And I think the answer is really having evidence-based programs that work. So when we funded our program, we did that through a generous grant from the AARP Foundation, but our goal was to demonstrate statistically significant outcomes in reduction in social isolation and loneliness, and therefore have our health system adopt the program. And so that's what we were able to do. Certainly that does require a little bit of a rigorous research process. I think there's a lot of opportunity there and a lot of variability. But I think health systems, health plans really look towards evidence-based programs that have demonstrated results. And so for us specifically, it was a reduction in social isolation and loneliness. I think for, and Sachin can speak to this, I think for CareMore's Togetherness program, I think there was decreased utilization. And so really, there's very little literature on evidence-based programs for combating social isolation and loneliness, but it's growing, and there are a lot of programs and companies like yours that have great evidence to show your intervention. So I think that's really key, having evidence to show that the interventions work and that they are accessible to patients.
And maybe just a really basic question, Sonja, how do you measure social isolation? What is that?
Yeah. So there's different ways to measure social isolation and loneliness. For the purposes of our research study, we used both the 3-item UCLA loneliness scale and the Duke Social Support Index. You can ask 2 or 3 questions. You can find it online for the UCLA 3-item loneliness scale. It's a validated screening tool to assess for social isolation loneliness. Very easy to do at a first visit with an older patient. So there are several validated screening tools, and I'm happy to share that in the chat.
Great. And Sachin, I think it looks like you were about to jump in, but are there different are there in your role now at SCAN and even previously at CareMore, is there a financial way that you can quantify the impact of interventions that focus on social isolation? Have you been able to do that?
Yeah, we did when we were at CareMore, we did an intention to treat analysis where we looked at folks who had not yet received the intervention, but who, for all intents and purposes, were a lot like the folks who did get the intervention. And we looked at differences in hospitalization rates, healthcare participation rates, in preventative screenings, as well as wellness assessments. And, we saw a decrease in lower rates of hospitalizations and lower, readmissions. I think, one of the kind of the reason I'm focusing so much on hospitalizations, I think, is that, the average hospital bed day in Southern California costs about $3,000. So when we talk about, generating savings, if you're able to very few other things in healthcare cost $3,000 per unit. And there's lots of expensive things in healthcare, but the thing that if you're able to avoid, if you're able to avoid a 4, 5, 6 day hospitalization, you're able to create, very significant savings. And so I think that ends up, from a managed care perspective, being the metric that you're really looking at: admissions per 1,000, bed days per 1,000. And so, I would urge folks who operate in this space to be thinking about, not just looking at the soft measures, but looking at the hard financial measures of, whether folks are well or not. And, it correlates because, if you go back to my opening comments about self-care, people with chronic diseases really need a lot of self-care to keep themselves out of the hospital. If they have CHF, they need to measure their weights. They need to titrate their diuretics. If people have diabetes, they need to manage their blood sugars very well. When people are lonely or socially isolated and don't feel like anybody actually cares about them, they often don't care about themselves. And so it's this idea of connection and sense of purpose that ends up, leading people to do the things they need to do to stay well, which will ultimately lead to lower hospitalizations and lower readmissions. That's the theory. Now, I do think that there's probably some room for, randomized controlled trials in this space of different interventions. And I think we need to hold ourselves to high, evidentiary standards. At the same time, I don't think we need to evidence-base everything, meaning like call your grandmother. I mean, really simply, like, even if there's no evidence to support that it's like, it reduced healthcare costs, it's the right thing to do. And I keep going back to this idea that if every person in this country thought about somebody who in their life who is lonely and just committed to checking up on them once a week, once a month, doing something nice for them once a week, giving them a sense of connection and purpose, we might end up not having forums like this anymore, just to be direct about it. So, and there's many societies that are better functioning than ours, where they do a better job of taking care of their seniors and staying connected with their loved ones. So this is cultural.
All right, we've in the last 5 minutes, I want to ask each of you the same question, and Ruth, I'll start with you. So, what is other than what Sachin has really emphasized, that there's a cultural dynamic, and we should call our grandparents and others more frequently, and that what is one thing that you would suggest or want to see different that would, in your experience, really alleviate the burden that older adults are facing when it comes to social isolation and loneliness?
I think that it is connected. People need to have the opportunity to communicate. To do that, they need someone to give them this opportunity in the way that works for them. So I think that people can help doing that. And this is a really important thing. I think that technology, the way we do it in a human touch way, in a natural way, in a seamless way, respectful way, gives opportunity for people to connect or ask for help or participate in something, right, that is out of their regular life, which I think is critical for well-being and for health. I think that technology is out there to help. It must be very respectful, and the way we see respectful is really utilizing rocket science to work in the background rather than in the front. So rocket science analyzing changes in health, analyzing without asking anyone to wear anything or to be proactive about it. I think that's what we're trying to do, and implementing the rocket science technology in the back to early detect the change, so the person gets the opportunity to participate in the care he deserves, whether it's around loneliness or it's around a deterioration of health connected with diabetes or other chronic condition, in the time that he or she needs it in a respectful way.
Thank you. Sonja, same question to you.
So I'll take the geriatrician's hat again, and really just to the clinicians that are listening in. This is part of our job. We need to be captain of the ship in caring for our patients, and really, we don't have all the answers. We can't do it all ourselves. We have to rely on our multidisciplinary team and our community partners to help us with our patients. But this is part of our job. We can't delegate this to someone else. We have to really recognize the importance of social isolation and other social determinants of health. It's just as important as diabetes and hypertension, if not more important. And so our raising awareness among ourselves and our colleagues is really critical. I think I saw a lot on the chat about that. And it's a health problem. And so we can have those conversations, and we might not have a program in our health system necessarily, but we can look into how to connect with our community partners that are doing the work already.
Thank you. And Sachin, last word to you.
For me, I would say pick someone in your life, anyone who you think needs a little bit more love, and give it to them. And encourage someone else to do the same. Yeah.
Thank you. Well, thank you, Sachin and Sonja and Ruth, and for spending this time with us and sharing your insights and your wisdom. And thanks to everyone for joining us. You will all receive an email with a survey. Please encourage you. It would really be helpful if you fill it out, provide us any feedback, and as well, any feedback you'd like the presenters specifically to our guests to see. And if you liked this program, I hope you'll join us for additional events. We have one early next month where we'll be featuring a longtime Matter member, Fibroblast, and Cerner Corporation, which recently acquired Fibroblast, talking about the ups and downs of that journey. You can see all of our events at matter.health/events. And with that, I wish you all a fabulous rest of your day. Thanks so much for joining us.
Thank you.